Yeah, I think it's a very good example of the perils of retrospective data. I mean, surgery. One of the conundrums in both surgery and interventional oncology, basically procedure-based specialties, is it's very hard to do prospective trials. It's very difficult to randomize patients to an intervention versus a non-intervention. It's not like a drug versus a placebo. So there just isn't a lot of really high-quality data in the surgery world or in the interventional oncology world, and so a lot of stuff just kind of evolves, like embolization and resection. And here you have a case where for decades people have looked at these retrospective analyses and said, wow, surgery improves survival even in metastatic patients. And then someone comes along and says, well, let's relook at the data a different way and do propensity weighting, which is not a prospective trial, right? It's just a different way of retrospectively analyzing data, and says, maybe we were wrong. Maybe if you actually weight these things, it turns out it all comes out in the wash and there really isn't a benefit to that. And I think what it tells you is you got to stop and think about this and say, okay, do we actually do a prospective trial of resection versus no resection in patients with metastatic mid-gut tumors? And then the problem becomes, well, if you were a patient, who would sign up for that? Right? I mean, either you want surgery or you don't. So it's very, very, that would be the ideal thing to do, but from a practical standpoint, is it really going to happen? It's very, very difficult. There's no placebo for surgery. So.